But we have a very interesting combination of speakers in this section. And Dr. Jane Morton is our next speaker. But I have to explain to you that Dr. Morton agreed to come about 2 weeks ago because we had a very interesting article, which I'm sure you've all read, in the latest issue of Breastfeeding Medicine, when Jane sent us a commentary on what she thought was going on in hospital care of breastfeeding infants and how it could be improved, and the most important step that could be taken. As editor, it was a beautiful article, but I couldn't let it lay. So I wrote a response to it to suggest that maybe there's another factor that might make the difference. And she has graciously come to speak. And now Jane is just not any old pediatrician. She went to Stanford and got a BA. She went to Boston University and got an MD. She did a residency at Stanford. She's been on the faculty. She's been writing papers. She's gotten award-winning videos. She's got lots of awards. But I want you to hear from Jane.
Ruth, I realize that's a lovely introduction, but I realize I have a huge deficit, and that is I didn't go to Rochester. So, at any rate, what I have found over my 44 years of being a pediatrician is that it's all well and good for us, all of us, to promote breastfeeding, but I think what is the most effective tool in promoting breastfeeding is having more of our mothers successful at breastfeeding. And for those who are unsuccessful, they very commonly talk about what a miserable experience it was and influence their sisters and their friends and so forth. So to really I think the strongest ally that we have would be successful mothers. Now, you all know that the drop-off in breastfeeding is tremendous after the first month, and mainly because of problems that, by and large, could have been prevented had we handled breastfeeding differently in the hospital. So that I think that where I have felt that I should put most of my energy in trying to help more mothers breastfeed is really right in from the very first hour after they're born. Now, I would applaud the Joint Commission for mandating exclusive breastfeeding as one of the important factors to follow for hospital quality care. But as we think of implementing, because as you all know, exclusive breastfeeding is in the hospital is strongly associated with exclusive breastfeeding out of the hospital. But in this article, and many around the country have become concerned that we may be trying to implement very good baby-friendly practices without the best strategy for implementing these strategies, practices, as far as keeping infants safe. So not only do we want to improve breastfeeding rates, but we also want to keep our babies safe. And this gets tricky given the fact that we have a much more complicated population of patients on maternity units these days. In the past, many of our preterm babies were all sent to the NICU, but now we have a population with a myriad of risk factors, with the poster child being the late preterm baby who is most likely to flunk at breastfeeding if that baby is handled the same way that a term baby is. So that when we start implementing principles of practice that are very good, very sound, I think what we need to do is to take into account the diversity of needs of all the patients, particularly those with risk factors, from infants to mothers as well. So what I'd like to do is to suggest propose a model that we might look at or consider that would incorporate some principles that would be much more supportive of these diversities. I would fully admit this is unvalidated. It's just what I would consider very reasonable and based on current research. So the success of any program that has to do with lactation, I think, requires the ingredients, 3 ingredients in particular. 1 is prevention, 2 is accessibility, and 3 is sustainability. Now you're probably thinking, isn't that intuitively obvious? But the truth is, prevention, accessibility or availability, and sustainability are precisely the 3 ingredients lacking in most maternity care centers. So let me explain. Let's talk about prevention. What are we trying to prevent? We're trying to prevent primarily 2 things. Mothers who are going to leave the hospital and not produce enough milk, babies who are going to leave the hospital and suffer the medical risks of not getting enough milk, mothers who don't produce enough, babies who don't get enough. Now, there is no stronger factor associated with the duration and the exclusivity of breastfeeding in any population, whether it's the mother who is pump dependent, whether it's the well-educated mother, whether it's the less well-educated mother. In every population, a robust milk production is the hallmark feature of longevity of breastfeeding and exclusivity. So in real estate, it may all be location, location, location. In breastfeeding, it's production, production, production. Now, production is exquisitely time sensitive and depends on the early, frequent, and effective removal of early milk called colostrum. Let me give you an example. If a mother expresses milk in the first hour compared to the mother who expresses milk in hours 2 through 6, she expresses 4 times the amount of milk in the first hour as she might if she started on hours 2, 3, 4, 5, or 6. And at 3 weeks, she's producing 130% more milk than the mother who began hours 2 through 6. So this is a very time-sensitive issue. We're not, as mammals, all born hungry the instant the umbilical cord is cut. But the rush to nurse, the rush of a colt to stand up on those crickety little legs, is all about phoning in your order to maximize milk production potential later on. We know up to 8 weeks, possibly even further. What you do in the first few hours is tremendously valuable. Now, our current management of breastfeeding is much more problem-oriented versus preventative. So we wait for indicators that may be suggestive of poor production, like the weight of a baby falling or the poor rise of a mother's milk production, before we get into a problem-focused attempt to improve production, when in fact we by this time have missed an extremely critical window of time. So the first, let's go to the second feature of availability. You all know that little problems in breastfeeding become big problems very quickly. Even unnoticed problems, unrecognized problems can become big problems. And big problems are less remedial, and they take a longer time to correct or to attempt to correct. So that when a mother at 2 in the morning turns to her nurse and says, "Is this right?" she needs someone right then and there to say, "Well, you know, it looks pretty good to me, but this baby was born at 36 weeks, so she might need a little bit more help. You let me know after you finish nursing her, and I'm going to show you how to just to take your hands, which happen to be more effective than a $2,000 pump, and we'll just hand express a little on a plastic teaspoon and top her off, and give your breasts more stimulation to produce, and your baby more of your own milk. So just give me a call after you finish nursing." But if she doesn't get that kind of care, in our current practice, what we usually rely on is referrals, which means delays in assistance. So when we rely heavily on episodic, problem-oriented care, we frequently find ourselves having too few people to do too little, too late for too few people. So we have a restricted number of beneficiaries that we deal with. So availability of care is another critically important thing that is missing on most maternity units. The third factor is sustainability. Now, there's this misconception that breastfeeding support early on is very complicated. The truth is, it's really not that complicated or complex. It's pretty easy to teach and easy to learn. But amongst doctors and nurses, there's sort of a stay away. This is way too complicated for me to figure out. While it is easy to teach and easy to learn, the pivotal point in keeping a care provider skilled is the continued use of those skills on a regular basis. We don't want to sink huge amounts of money into training nurses if all they're going to do is to write an order for a lactation consultant and think they've done their perfect job. It would be a paradigm shift to have nurses become providers of skilled, critically needed lactation support, and for lactation consultants to leverage their contribution by becoming teachers of nurses. Lactation consultants in this way could be part of the team of prevention rather than part of the team of putting out fires. So, respecting the constraints of time, skills, and resources that hospitals have, what I would like to suggest is a 3-step plan that could easily turn this around. The first step is easy. Representatives of caretakers and stakeholders, of which there are many, would meet and agree upon a baby-friendly hospital policy. I particularly like the American Academy of Pediatrics baby model breastfeeding policy simply because it's so simple, and I'm into keeping things really simple. But at this meeting, the other thing we would need them to commit to and have a consensus on is steps 2 and 3. So step 2 would be to provide all bedside nurses, including obstetrical nurses, because of course that's one of the most important places to begin, with a very coned down, streamed down curriculum with core competencies that focus only on the first 3 days, nothing more. And a very organized approach to this has been called the mnemonic ABCs. A for attachment, the baby at the breast, B for breast milk production, and C for calories, or just metrics that indicate normal, adequate milk intake on the baby's part. So ABCs, simple steps that need to be taught and learned. The third step is the linchpin for sustainability. And that would be that every morning or once a day, at the bedside, not at the nursing station, but at the bedside, there would be rounds, the mother and her baby, her bedside nurse, and a lactation consultant. And they focus on the ABCs. What skills need more tutoring, who, where, when this is going to be taught. That might look like the lactation consultant right then and there helping a nurse, showing her how to teach a mother. It might look like offering the mother participation in a group breastfeeding class in the next few hours on the ward, taught by a nurse and a lactation consultant. It might be relying on audio-visual aids, and videos have been the keystone for training staff and mothers in many hospitals. For example, the videos that we put together on the Stanford website are the most frequently visited links of any links in the entire university. But I think they're woefully inadequate. And maybe it's just because I live in Silicon Valley. But I see these incredible tools used to teach cardiovascular surgeons how to do operations, and obstetricians how to deliver babies, and some of my friends how to play golf. And there are these amazing, interactive, culturally sensitive, electronic simulation tools that would be so valuable for mothers to look at someone who looks like her, or maybe is her, that could abbreviate the amount of time, not eliminate, but abbreviate the amount of time that nurses need to spend teaching. So that I think this is where we really are lacking, is a tool that basically goes over the ABCs that a mother needs to know during this focused period of time, that we could do better here. So in summary, I think we need a critical mass of skilled, accountable bedside nurses to maintain a preventative, accessible, and sustainable system, and in that way, we could have the magic of baby-friendly care really flourish in our practices without sacrificing the health of any newborn or the outcome of breastfeeding rates. So I think, in my optimistic way, that this is the perfect time for a bold change in the way we manage lactation in our hospitals. Thank you very much.